Well, thanks so much for joining me today for the second episode of Season 4 of the Healthy Skeptic MD podcast. I'm Dr. Michael Hockman. I want to begin again today by acknowledging the SCAN group, the SCAN Health Plan, where I currently work, for funding this podcast. I have a great guest today, Dr. Jason Karlawish, one of the nation's experts in dementia. He's at the Penn Memory Center, and he wrote a great book recently, The Problem of Alzheimer's Disease, which I just finished. It's great. I would really recommend it. Check it out on Amazon, wherever you buy books. In it, he covers Alzheimer's soup to nuts, everything from the medications that are available, how you diagnose it, what social interventions we need to do, what societal changes are needed to improve care for those with dementia. And that's exactly what we're going to go through with Dr. Karlawish today. So stay tuned for that. If you do find today's episode engaging, please do search and subscribe to the Healthy Skeptic MD wherever it is you listen to podcasts. Please check us out on YouTube. Again, Healthy Skeptic MD is what you want to search for. Leave a review if you have a chance, and please do pass us along to friends, family, and others who might be interested in listening. So before we jump into the interview with Dr. Karlawish, let's do a rundown of the health news of the week. And I actually want to just cover one topic that's directly relevant to our interview today. So last week, the FDA approved the first new treatment, pharmacologic treatment for Alzheimer's disease in nearly 20 years. Now, as you will learn in our discussion today, existing treatments for Alzheimer's disease are, to put it mildly, not particularly helpful. At best, they are a band-aid to help manage symptoms. In many cases, they don't even do that particularly well. So what's potentially exciting about this new drug, which goes by the name aducanumab, or the brand name is Aduhelm, is that it actually blocks formation of those plaques that are found in the brains of patients with Alzheimer's disease. So theoretically, this might mean that it not just alleviates symptoms, but may actually slow progression of the disease. So what's all the hullabaloo? What's all the controversy here? So the reasons are multifaceted, and actually Dr. Jason Karlawish, my guest today, has been quoted quite a bit in the media this week. So here's what he said in the New York Times. He said, "The data are murky, and even if they were clear, the drug's benefits are ambiguous at best and not worth the cost." So why did Dr. Karlawish say this? Well, there's several reasons. Well, first, in terms of effectiveness, the drug isn't actually all that effective based on the data we have. There have been two rigorous studies so far. One did not show any benefit whatsoever. The other did show a mild benefit in terms of cognitive function and patients' ability to do daily activities. But this was an after-the-fact analysis, and there's a high risk of errors when you do an after-the-fact analysis, so not terribly rigorous. Another reason is that this is actually a medication that's administered through an infusion once a month, so not the easiest medication to take. There are a number of rare but serious side effects, so brain swelling. There was even some risk of brain bleeding. There was also a high rate of headaches, falls, diarrhea, and confusion, so also some not great side effect profile. And the price tag for this, the annual cost, is $56,000 per year. Now, as Dr. Karlawish has pointed out, there are many other things we could do with $56,000 for patients with Alzheimer's, such as hire someone in to go in the house and help them with those daily activities, or provide better counseling and mental health treatment. So the FDA's advisory committee actually recommended against approval of this medication, and the FDA went against its advisory committee's recommendations and went ahead and approved it. So I'm on Dr. Karlawish's side today. It's exciting that there are these new drugs that potentially in the future could slow the progression of this very serious disease, but the data just do not support its use right now, certainly not at the current price tag. And we'll certainly delve more into that in today's interview. So let's jump into our interview with Dr. Jason Karlawish. Well, welcome to the Healthy Skeptic MD, Dr. Jason Karlawish.
Thanks, Michael. It's great to be here, and I'm really thrilled to be part of this collaboration with SCAN.
Well, really good to have you. And you're here from the Penn Memory Center, and we're going to talk a lot about your research and the book you just wrote, The Problem of Alzheimer's. But first, you're a practicing clinician. Where do you see patients at Penn?
Yeah, so I'm on faculty in the School of Medicine at the University of Pennsylvania, and I co-direct the Penn Memory Center. And every Friday, I see patients for diagnosis and follow-up care. And they're coming in because they've noticed some cognitive problems. So much of my practice is around the diagnosis and treatment of persons with diseases like Alzheimer's disease and other causes of cognitive impairment later in life.
And you also, of course, are an author, but do you do research as well?
I do. I have a lab. We call it the Penn Program for Precision Medicine for the Brain, or P3MB. It's a multidisciplinary team of researchers in philosophy, anthropology, psychology, neuroscience, and we study issues at the intersections of ethics, law, and policy as they relate to the technological transformation of the way we measure the brain. And a lot of that's been focused on Alzheimer's disease and the rise of technologies to identify the disease, not in death, but in life, the biomarker type technologies. But that's just one example.
Well, you're certainly on the frontier of Alzheimer's disease and dementia. We're going to spend most of our discussion today on the frontier, but I just almost finished your book, and there's just so much rich background, and I wonder if we could just start with the basics. If you could just define for the audience, what is Alzheimer's disease? What's dementia? Are they the same? What's the difference?
Yeah, no, much like the disease, which causes people to have repetitious questions, probably the most frequent question I hear is, what's the difference between Alzheimer's disease and dementia? And indeed, I open the book with just that question and attempt to answer it. So dementia describes disabling cognitive impairments. So someone has troubles with memory, attention, concentration, spatial function, and those cognitive problems are causing them to be unable to do activities they used to do independently. Order off of a menu, pay a bill, refill medications. Someone else has to help them. So that's dementia, disabling cognitive impairments. And then Alzheimer's disease is one of the most common diseases that causes dementia. There are other diseases that cause dementia. Lewy body disease is one. Robin Williams, the comedian actor, had that. Frontotemporal lobar degeneration. In the 19th century, untreated syphilis infection was a very common cause of dementia, called generalized paralysis of the insane. So Alzheimer's disease is the most common cause, we think, of dementia, disabling cognitive impairments.
So Alzheimer's, as you describe in your book, is just rising at a very rapid rate, becoming a much greater societal problem. It's often described as a tsunami of older individuals. Just what's the impact, financial and otherwise? How many people have dementia, Alzheimer's dementia, and how is that expected to evolve in the coming years?
Yeah, so it is a problem, and certainly the word problem, I think, applies, told with some rather spectacular facts and figures, beginning with the prevalence. You know, right now, depending on how you count it, and that's been a source of ongoing debate since the 1980s, but depending on how you count the disease, there are probably about 5 million to 6 million people with it. And the equally compelling statistic is there are at least 12 million people who we consider caregivers. And I'm sure we'll talk more about what it means to be a caregiver. And the disease is typically framed as costing America somewhere in the triple-digit billion-dollar figure a year. Depends on how you count it. And the fascinating point that I bring up and talk about in the book is much of that triple-digit billion-dollar figure is the labors of caregiving, the time spent either providing care and or paying someone else to provide care. And if you add that cost up across those millions of patients and caregivers, that's where you get to this triple-digit billion-dollar cost to America. And as you said, it's becoming an increasing problem, and the reason is because one of the chief risk factors for developing dementia, just dementia, is age, chronologic age. And among the fastest growing age groups in developed nations, America being one of them, are persons over 75, 80 years of age. And of course, it's after those ages that cognitive impairment becomes all the more prevalent, whether it's caused by Alzheimer's or other diseases. So it's a big problem, and it's getting bigger. Yeah.
And one reason that you mentioned in the book that is hitting the United States particularly hard is our culture compared to others. We don't have that longitudinal, older adults staying in the family, as it happens in many Asian countries where older individuals with dementia will just live with family. Is that a contributor as well to the challenges we face?
Well, yeah, no. One of the points I make in the problem of Alzheimer's is how culture sort of contributed to turning late life cognitive impairments that could have been thought of as, well, maybe it's just aging. One of the reasons why it became, no, it's a disease, is in our culture, lots of things changed over the course of the 20th century. And one of those things that changed was the American family structure, and the family structure in general. Smaller families, spread out, and frankly, we began to simply step away from the idea that there are these default unnamed, and that's the key thing, unnamed caregivers who will just take care of that disabled older adult, typically a spouse, a wife, a daughter-in-law. And you're right, to the extent that a culture hardwires into a culture that, there'll always be a family member whose job is to essentially be a caregiver. We won't even call her, and they're usually a caregiver. It sort of takes the problem out of being a problem. Now, of course, for her, it becomes a problem because she sort of has been told, this is your role in life, choose this. Well, you don't choose it. You're just going to do it, And you mentioned Asia. I think we have to be careful when we pick countries, but I will say I had colleagues in Mexico who said that one of the reasons why Alzheimer's went from 0 to 60 in Mexico as a problem was the rapid change in the Mexican family, namely the shrinking of the family size, the dispersion of families into major cities, and therefore the loss of, and they were very plain, that third or fourth daughter who always stayed at home and never left home. And so she was always sort of there to take care of people. And I find that interesting because, of course, that meant she had to surrender some of her autonomy, frankly, much of it, to sort of be available as a home person. So that's one of the reasons, not the only reason, but an important reason why this became a disease. Yeah,
I actually want to pick up on that point of long-term care, which you have a whole chapter on in your book. What is long-term care insurance, and why is it a problem that many of us don't have it?
Yeah, so long-term care social insurance is just that. It's a national social insurance program to de-risk the chronic costs and morbidities and harms of providing care for someone who's chronically disabled, whether that's from dementia, heart failure, arthritis, etc. And this country does not have a long-term care social insurance program. We had a couple of efforts starting in the late 1980s to create one, and they failed politically. I do sense some changes, though, in the wind. Having said that, though, unlike, say, Germany, Japan, and most developed nations, we lack that in this country. We do have long-term care insurance that you can go and buy from a carrier, like you can go buy car insurance. It's very undersubscribed and underused.
What percentage of Americans do subscribe to private long-term care insurance?
5-10%. And it's not growing, it's shrinking, and the carriers are walking away from that business. I'll say personally, my parents have those policies because they were of an era when the employers were really pushing them, and they worked at businesses where that was for a while a benefit they were pushing. And, the policies certainly are attractive in principle, but when I look at what the policy offers, it's essentially not until severe stage disease is it going to be useful for my parents. So, they're not the solution. And as I say, that more importantly, the firms are walking away from it.
And in many cases, in my experience, if someone's poor enough or they spend down their resources enough and they qualify for Medicaid, that's the only way that the public insurance system would cover their long-term care.
Yeah, no, right now in America, basically, if you're very rich, you can just pay for this instead of, say, buying another house or a couple boats. And if you're poor, you do qualify for Medicaid. But there's rationing, quite frankly. I mean, Medicaid's long-term care services and supports are on what are known as a waiver program. They've been that way for decades. Biden intends to end that. He has to, and I think that makes a lot of sense. But for the vast, neither rich nor poor, otherwise known as the middle class, they're left on their own to pay for care. And you're right. I mean, for many families, this presents an enormous economic challenge. Namely, family members have to leave the workforce or reduce their work or not take promotion at work, and also otherwise spend resources that could be spent for other things, other generations, for example, in their education.
Before we get into what's new and on the horizon for Alzheimer's disease, one other question that comes up, I'm a primary care doctor, and one of the most common questions I get from my patients, and even friends friends and family is, I'm having some memory problems. How do I know if this means I'm developing Alzheimer's or dementia? And is there a test to tell me if I am?
So memory problems are very common starting at around the 50s, namely tip of the tongue word finding problems, But I would recommend folks have a look at the Alzheimer's Association has the 10 warning signs, which list out the 10 warning signs for cognitive changes that we need to look into this. Repetitious questions. In other words, you ask the question, it's answered and by someone and you ask it again. Repetitious stories in the course of an episodic conversation. Troubles and or inefficiencies doing cognitively demanding tasks. In other words, mistakes or struggles with the checkbook or putting together a Thanksgiving meal where the person previously was quite adept at that. When I hear stories like that, I say that needs to be evaluated. Troubles recalling what's the name of that flower that you haven't seen in 10 years. For me, it was lilac yesterday. That's a word retrieval problem, which is related to age-related changes in nerve function, neuronal function, for example.
And as I always tell my patients, you try to really uncover whether these memory problems are having a big impact on your life, and that's also a big indicator.
Exactly. It's the inefficiencies in doing daily activities and or impairments, which is why when I work up a memory problem, I really need to talk to some other people to get input about what's the clinical impact. And I'll tell you, both professionally and personally, I've seen it's just the most fascinating thing. Folks with a memory problem, they may say they struggle, but there's a real sort of adjustment that occurs such that it's hard to see how it's interfering with daily life.
Yeah, and it's often said that if you are worried that you have a memory problem, it's probably not Alzheimer's or dementia because,
Well, what that sentiment is getting at is if you're saying all the things you can't do because of your memory problem, that's not typical for cognitive problems seen from diseases like Alzheimer's. That's more probably related to anxiety.
Yep. I think that's a good point. But a lot of what I do in primary care is reassuring people that the word finding difficulties, the name of the flower, as you said, that's not necessarily a sign of dementia, and I can be a little bit reassuring there.
Exactly. I think the key thing that I think we need to start as a society encouraging people to do is to start developing trusted networks of people who watch over each other. If you're noticing I'm having problems, I want you to tell me. Or I want you to tell my spouse, or I want you to tell my kid, or I want you to tell the other person in the network to then come to me and say, we're a little worried about what we've noticed. I really have a vision of the future where we have a much more interconnected kind of self, that is to say, watching out over each other with the freedom to sort of signal problems when they're noticed.
Well, that's a good springboard for the next set of questions I want to ask you about, and that's the treatment of Alzheimer's disease and dementia. So there's two main categories. There's medications, and there's behavioral and social interventions. The simpler one of those is medications. So let's start with that. What is currently available for treating Alzheimer's disease in terms of medications?
Yeah, what's currently available are medicines that I think are best thought of as palliative, medicines that in some way go after some of the symptoms. There's drugs which have an effect on cognitive function, mild, and has some translation into functional skills. I think the general consensus is just that. The efficacy is a bit mild. Nonetheless, they're used. And I talk about their sort of, I'll say, sick and twisted history that led to their development in the late 80s, early 90s. And then there are drugs as well to palliate some of the more common problems with mood, anxiety, depression, and some psychosis that can lead to agitation and real disruptions in quality of life. So that's the pharmacologic side of things. There are a lot of exciting drugs under development, none of which, though, I can right now, type into Epic or an order for prescribing. But, I think there's optimism that something may someday be available.
Yeah, I think the medication area has been an area of disappointment. I remember in medical school 15, 20 years ago, there was a lot of enthusiasm, and none of these has proved to be a true blockbuster. As you said, they're mainly improving symptoms, not to say that there's no value in that, but they're not real game changers.
Yeah, I mean, they weren't targeting the pathology. I mean, the companies attempted to try to make that argument. And, Anyway, what's my point? I mean, back when you and I were in med school, we didn't have the ability to see the disease in a living person. So I think, many of the studies that tested drugs in persons with Alzheimer's disease, a substantial fraction of them didn't have it probably. And we found that out when we started doing the biomarker tests in clinical trials, that about 20% of the people in the clinical trial actually didn't have Alzheimer's disease. So much of the research that was sort of 5-10 years ago and beyond or back, really, I think it set up an infrastructure, but I'm not confident we were often even studying Alzheimer's disease.
And one other question is about the existing medications, like Aricept, for example. How well do these medications work, and how are the side effect profiles?
Well, as I say, you could see clear drug versus placebo differences on global tests of cognition. Translating that benefit into some effect on function has been more elusive. Having said that, I have, about half the people I put on them, will either they or their family will say the person seems a little sharper, a little clearer. The other half say I don't simply notice any difference. The side effects are largely gastrointestinal. There's also some, for some individuals, bradycardia that can necessitate actually stopping the medication.
My experience has been similar, that they may improve some memory and some modest improvements, but I typically don't get great feedback when I use them in primary care, and sometimes we will stop them if we're not getting a benefit, and there are some of those side effects.
Yeah.
So in terms of the horizon and trying to address not just the symptoms, but the disease process itself, what are some of the more exciting? I know you said there's nothing you're quite ready to write for your patients yet. We're still a few years away from that, but what classes of medications are on the horizon?
I chronicle in the book, the last 20 years really were leaps of progress in being able to measure the disease in a living individual. Using PET scans that pick up amyloid, and now they can do it with tau, the two pathologic markers of the disease. There's even great promise now for blood tests that can detect those pathologies in life. And that allows you to pick people who can potentially get a drug and also monitor the drug's effect on the pathology in addition to its effect on how the person functions in the daily world. There's been a lot of progress in developing treatments that target amyloid. And we're beginning to see some sense that there might be certain kinds of treatments that go after certain kinds of amyloid. The soluble oligomers seems to be a hot area that maybe are affecting the natural history of the disease. There were a lot of failed trials over the last 10 years, and I think we've learned a lot. So there is a drug right now under review by FDA called aducanumab, manufactured by the company Biogen. I personally think the data they've handed the FDA are very difficult data. They stopped the studies early because of the futility analysis, et cetera. I think the drug needs more study, but it certainly has promise. But there are other drugs behind it that show similar promise. I think the key theme that I think most reasonable folks take away from what we're seeing, we should expect someday drugs that can change this sort of natural history of decline, slow that curve down of decline. I think the notion that we're going to sort of, drug our way out of this problem, halt the disease, reverse it, is I think, I kind of compare that to sort of buying lottery tickets to plan for your retirement. You might win, and if you do, you're going to win big, but it's highly unlikely that you're going to win. So those drugs are in the works, and there are also drugs now being developed to go after tau, which is another key component of the disease. So, I think there's optimism, but I myself am cautious with setting timelines and things like that. I think the pace of things has shown us that, unfortunately, things are moving, but they're moving slow.
Would you say once someone has advanced disease, damage to the brain, it's very unlikely that we'd be able to get a medication that would reverse it, but more the hope is that in the early stages, as you said, you could block the process and slow the progression?
Well, I think that's, I think we should be careful about, some of the semantics here can lead people to, blocking the process, in my view, would be like, getting those 2 shots of the Moderna vaccine or the one of the J&J one, and, you're not going to get COVID probably, right? I think that here we have to be careful with our language. I think what the data show us is we can slow down the pace, if you will. So let's put it simply. It's someone with mild inefficiencies in daily activities might take another year or two before they become disabled in those activities because of progression of the disease. So you're sort of delaying progression, if you will. That's enormously promising for an individual, but also if you add it up across the millions of people, that would reduce the burden of disability. It also increases the cost of therapies. But, we do that across a variety of diseases, cancer, et cetera. Many of these diseases become chronic diseases, not necessarily cured, but maintained and abated to the degree the person can carry on with their life.
Yeah, so that's an important expectation to set, that it's unlikely there's going to be a magic bullet pill that's going to solve this crisis. And that's why the other class of approaches to treating Alzheimer's and dementia, the social and behavioral interventions, are so important. And you talk so much about these in the book. Just what are social and behavioral approaches to managing dementia and Alzheimer's?
Yeah, well, like any chronic disease, people have a lot to learn and have to identify what their problems are caused by the disease and come up with solutions to them. So, it's no different than learning how to live with heart failure or diabetes or any other disease, which, while it's treatable, not curable. So I never have felt that cure and care in this disease should be juxtaposed in some sort of weird competition. So in the case of persons living with dementia, the person with the disease and their family member, the person we often call caregiver, they need to know what the disease is. What's the cause? Is it Alzheimer's? Is it Lewy body disease? Is it some combination of other diseases, et cetera? Number one. Number two, what stage are they at? What to expect in the future? How to manage current problems? How to access the needed services and supports to manage those current problems? And then what to expect in the future and how to plan for that future. Those are all skills. They're no different in some sense than learning how to live with diabetes. What should I eat? What should I not eat? How should I tailor my exercise? What are the signs of low sugar? What are the signs of high? I mean, we provide that routinely to diabetics, but we don't provide that same kind of education and training to caregivers and family members. They're left to figure it out on their own or go to a self-help group, namely the Alzheimer's Association, and get that information. But none of that's well integrated into typical healthcare systems. Physicians make their diagnosis best as they can, prescribe a few treatments, and then folks are kind of left to figure it out on their own. If you lived in the Netherlands, every person diagnosed with dementia is assigned a care manager. And that care manager's job is to provide just this, education, training, and access to necessary long-term care services and supports, like, say, an adult day activity program, so that the person has something to go a place to go to during the day that's safe, social, and engaged. So, yeah, we don't have that in America. We need it, and it's just going to take the political will and courage to create it.
Are there any examples of health systems that are doing it at a small scale level here in the United States that might be examples to point to?
In Indiana, Indiana University Group's been good with setting up a network of primary care practitioners who have decent access to referrals needed, but also the skills to diagnose, and as well access to sort of care coaches, care managers. The story tends to be one of healthcare systems putting something in place, but then struggling to support it because the business model isn't robust. And so, you find yourself oftentimes up against the sort of limits of being able to pay for what should be, routinely available things, because the business model, the revenue generated, is just not. In our current system, a disease does not exist unless it has a business model, and dementia, Alzheimer's disease, and other diseases that cause dementia don't have a good business model right now.
Is there a policy change at the federal or state level that could help mitigate that concern?
Yeah, I mean, Medicare, through the Center for Medicare and Medicaid Innovation, CMMI, has been working on developing and disseminating what's called Comprehensive Primary Care Programs, CPC. And in the CPC network, funds are given to sort of manage the overall population with recognizing the triages of risk, where one of the top risk groups is people with a diagnosis of dementia or Alzheimer's. And the resources available through that program provide access to care management and care coordination. I think that's very promising. I just think the problem is it's one of these sort of programs that comes and then goes as it's being sort of tinkered with. It needs to just become part of the Medicare benefits package, and not something that's done because this health system's decided to try it out, but then it changes 5 years later, et cetera.
So as you mentioned before, this podcast today, Healthy Skeptic MD, is in partnership with SCAN Health Plan, which is a Medicare Advantage plan. Do you see Medicare Advantage plans as being able to, without any policy change, to opt to reimburse some of these services? Is that something that they have the ability to do right now?
Yeah, I think I'm not an expert on what an Advantage plan's sort of advantage is, and I don't say that with any pun or cheekiness intended. But my understanding is they're given more flexibility with how to sort of spend the benefits, if you will, or the resources. To set aside the word benefit, these are just, and I would think a smart Advantage plan would see a tremendous value in providing the kind of long-term care services and support, such as care coordination, patient, family, caregiver education, to individuals with dementia or other and diseases like Alzheimer's disease and other diseases, because quite frankly, you're going to save it down the road because you're going to reduce things like frequency of emergency room visits. That's been shown. If you provide these kind of services, you reduce ER visits and other events that represent sort of cost to the system because of unnecessary use of care.
So there's some behavioral approaches, some case management that could really make a big difference in managing individuals with Alzheimer's. You mentioned before in our discussion about social interventions, social connectedness and networks and so forth that maybe are not as amenable to the traditional healthcare system. You have any ideas about how we go about creating those networks in the United States to create that support network?
Yeah, we have a loose non-network of what are called adult day activity programs, and they struggle to make budget. In fact, I chronicle one in the book, and I sadly during the pandemic got an email from the director of it saying we're shutting down because we've not been able to weather the fiscal storm because of the pandemic and the loss of our clients. And I thought that was very sad because, of course, lots of programs within healthcare systems also struggled during the pandemic. But they weren't shut down because the system was able to sort of shift the costs and, get through the storm. But most adult day activity programs are freestanding enterprises, not-for-profits, managing with maybe a small endowment at best, living off of VA revenue because they take veterans, which used to be reasonably well compensated, Medicaid revenue, and then private pay. Namely, the families pay about $70 a day. It's sad because if they were adequately resourced and embedded in the healthcare system, they could really serve individuals and be better structured. I mean, a lot of them struggle in their space, and they mix together a fairly diverse case mix, excuse the language, in terms of severity of impairment. Many of them would like to have more room to really take in people who are only mildly impaired, have programs separately for those who have more severe impairments. So, there are great models out there. Again, the Netherlands has a great model of adult day activity programs where they really tailor the place according to certain aesthetic tastes, number one. And number two, they really try and create spaces recognizing the varieties of the disabilities people have, as opposed to bundling everyone in one room, for example.
Well, it seems the COVID-19 pandemic was a particular challenge for programmed adult day healthcare centers because those are the populations that were hit hardest by the pandemic. And I've just seen in my own practice, those are the individuals who have been struggling the most during this pandemic with social isolation. They don't have the usual programs and social networks that they have, which are limited at baseline. Is that something that you've seen in your practice that has been a particular challenge for the elderly?
Oh, yeah, absolutely. I mean, COVID laid bare the need for care and caregiving. COVID laid bare and showed plainly as an awful natural experiment the importance of community-based services and supports, because when those services and supports were taken away, our patients suffered. Our family members were calling us desperate. When the caregivers were taken away from the ability to see their relatives in residential facilities, their relatives did very poorly, lost weight, developed agitation, developed deconditioning. CDC has already documented an increase in over and above the expected death rates, not simply explained by COVID, and it's explained by taking away caregiving. So, if there's a copper lining to this pandemic, it's not even silver, I'll have to say, but copper lining, it's that we learned the importance of care and caregiving. When you take it away, how much people suffer. So then the next question is, well, how good was it when it was there? And now that we know it's important, how good was it when it was there, and how can we improve it? So maybe going forward, as part of our nation's sort of rebuilding that our president Biden is doing, maybe I hope that this will be part of that effort.
Well, one of the hardest questions I've gotten from my patients during the pandemic is, can I visit my older grandmother with dementia? And you're balancing the social benefits of that visit with the risks of COVID. It's getting a little easier with the vaccine, although vaccination has been unfortunately a little slower than it could be because many of these homebound elderly are not able to access vaccination sites. So there have not been enough programs to go into people's houses to get the vaccine. But that's a side note. Is that anything you've experienced in Pennsylvania?
Well, COVID was devastating to residents in long-term care, residential long-term care, as well as people in the home who needed folks to come in and care for them. We were in this state, persons over 65 were top of the list to get vaccinated. And so we're able now to allow visitors to come we are now able to allow visitors to come to the facilities. Even before vaccination, we were opening them up as the rates dropped, so people could visit. It made sense early in the pandemic to lock things down. We had no idea of how truly infectious this was. We had no idea how much more it would spread. In some communities, we saw the tragedies of overwhelmed hospitals where, ICUs were at 100% capacity. That meant someone who needed the ICU probably didn't get it. Anyway, but, I think as things stabilized, I think, we recognized the need to balance the risk of isolation with the benefits of isolation versus having visitors come in. And I was among several who really advocated for the need for more sensible, quote, visitation policies that recognize the role of a family caregiver as not just a visitor, but as a caregiver.
Yeah, I think it's really hard to get that balance right. And I think, maybe appropriately, understandably, we erred a little bit too much on the side of caution about the COVID disease and less about the social impact that was having. But not an easy decision. And very tough policy choices to be made there. Well, Jason, my last question or two for you has to do with what's ahead for the next 10 years. Our population is aging. Maybe we have some lessons learned from the pandemic. How do you see the Alzheimer's landscape evolving over the next few years?
I'm cautiously optimistic that we're going to see the ability for some people to benefit from tests that identify the disease early and drugs that slow the rate of progression. And I say some people because we've learned how complicated and heterogeneous this disease is. It's not a simple set of pathologies. There's a lot of heterogeneity. But I do think we're going to start to see drugs carving out the disease. So I'm optimistic there. I'm cautiously optimistic that once there's that business model that American medicine loves, that we'll see an uptick in people going into this field. Certainly at the Memory Center where I practice and do my research, we're seeing more folks wanting to train and go into this space compared to a decade ago. And I'm also cautiously optimistic that we're going to begin to rejigger society. We're going to create a society that lets people live well with cognitive impairment. And we talked about how it'll involve long-term care services and supports, but I think it's also going to require institutions we don't usually think are part of the Alzheimer's problem, part of the solution to the Alzheimer's problem. For example, the financial services industry. They recognize how they're really on the forefront of identifying people with cognitive impairment. Any big firm will tell you, clients over 75, they're pinging all the alerts for odd cash transfers, and other kind of transactions that raise concerns of abuse, exploitation, or neglect. And, we need to think about how to conduct our financial services industry in a way that maintains not just our nation's wealth, but its health. And I think many firms have recognized that. And I'm cautiously optimistic that someday, for example, there'll be a better integration of the warning signs picked up from the financial services industry with the kind of warning signs my colleagues and I care about and need to know about. And then, I think we should expect a revolution in technology. I think the Internet of Things really offers a lot of opportunities for detection of cognitive problems and for monitoring of cognitive well-being that won't rely on what arguably is a fairly frustrating for some and antiquated practice and even discriminatory practice, namely I need to talk to other people to find out how you're doing. It's frustrating because it takes time. It often is inaccurate, and it's discriminatory in a way because if someone doesn't have close other people because they're single, for example, or don't have children, they don't have that immediate luxury of other people to talk to. Having said that, though, I think technologies to monitor and detect artificial intelligence, as promising as they are, we mustn't think that they can replace the role of humans. I mean, this is a disease that is a uniquely human disease, and it really does take a human mind to take care of a failing human mind. You can't just substitute technology for that. And I argue that pretty, clearly in the book.
Well, that's a great sentiment to end on, Jason. I'm just going to summarize the key points that I took away from this discussion. Certainly got a lot of pearls. One of the big ones is that we really are facing a tsunami in the coming years. There's going to be huge financial impacts, and as the demography of our country changes, there's some exciting technological progress, some medications that may make a difference, but there's probably no magic bullet out there. And for that reason, we're going to need to keep in mind the social and behavioral programs. Right now, there's not a great business case, so we're going to need some policy changes, perhaps with the current administration, to create that so health systems can do their thing, and also the social programs at the public health level to make a difference. And maybe we have to think more creatively about how to use technology, not to replace humans, but to use technology in a way to better communicate with homebound older adults suffering from dementia. Well, it's going to be a great field to follow in the coming years. I just want to thank you, Jason, for joining me today from the Penn Memory Center. It's a great book he just wrote, The Problem of Alzheimer's. Check it out. I'll link on our podcast website to the information. And a big thanks to Scan Health Plan for supporting our discussion today. Thank you so much for joining me, Jason.
Yeah, thank you, Michael, and thank you, Scan.
Until a couple weeks from now, take care. Thank you.